My hope is always to bring the patients as much information as they need to make the right decisions for themselves and to bring them evidence-based information specifically, just simply educating people about what are thyroid nodules and what are they going to do over time and how will they affect me. And there's so many things just around that kind of education that are incredibly important, and only ever want to operate on people that I will help. Right? Like I don't ever want anybody to just say, whatever you say, doc, sign me up for it. I'm good. I want them to understand and really truly have informed consent to a procedure. Why don't you actually publish a study about how it's affecting your patients and how it's helping, or if it's helping?
I have just 30 seconds just to tell someone why they should save their thyroid. What would you say?
Oh gosh, I would say because it's possible.
Welcome to Save Your Thyroid, a podcast all about thyroid nodules. My name is Jennifer Holcomb, and I advocate for fellow patients suffering with this very common condition. Thyroid nodules impact 70% of adults in their lifetime, and the standard of care is surgical removal of half or all of the gland. But in recent years, safe and effective non-surgical treatment options have become available. In this podcast, I sit down with patients and physicians to discuss life with thyroid nodules, treatment options, and how to save the thyroid whenever possible. Today's guest is Dr. Elizabeth Cottrill, an associate professor of otolaryngology, head and neck surgery at Thomas Jefferson University Hospital in Philadelphia. There, she also serves as the residency program director and the surgical director of the Jefferson Thyroid and Parathyroid Center. Her research focuses on cancer diagnostics, clinical outcomes, and patient education. Her clinical practice focuses on the treatment and management of patients with thyroid and parathyroid diseases. And she also has a special interest in advanced and aggressive forms of thyroid cancer, as well as non-surgical ablative techniques for benign thyroid nodules. Dr. Cottrill, welcome to the podcast.
Thank you so much, Jen. It's wonderful to be here. Thank you so much for having me.
Yeah, fantastic to get to talk with you. We were just talking a second ago about how we just briefly had a chance to meet in Nashville last fall, but we didn't really get a chance to talk. So I'm excited today to get to talk with you and get to know you better. So let's just start off with you introducing yourself. Tell a little bit about your background and your training in otolaryngology.
Sure. So I grew up mostly on the East Coast. I moved around a lot as a child, had a big family, and eventually I would say West Virginia is kind of home. So we'll call that home base, even though it lived in about 8 different states when I was growing up.
Wow.
We ended up staying there for most of my high school training. I went to Vanderbilt for undergrad, and so I found myself in the South for actually quite a few years, both undergrad and med school. In undergrad, I majored in philosophy, and my sort of personal favorite sort of niche was medical ethics. And that's kind of where I found a lot of inspiration for what I do today, and still kind of use that a lot in the kind of research that I do and the way that I talk to patients and the way I take care of patients. I did residency training at Penn. So I moved from the South to Philadelphia, and after that did a fellowship in head and neck surgical oncology at Penn State. So stayed in Pennsylvania, and then back to Philadelphia, taking a job at Jefferson. I've been at Jefferson now for about 7 years. I just finished 7 years here and starting my 8th year. I just became the program director for our residency, which is a really big responsibility and also a big honor to be able to lead that group. So that's kind of how I spent my days and my time. Over that 7 years, my training has been so exciting to be in a field where even after your fellowship, you're still learning new techniques, such as radiofrequency ablation. I just love being in a field, both a surgical field and a medical field, where there are advances, there are new things to learn. It's just, I'm always hungry for that. So
constantly advancing. Yes. And I feel like today, especially, technology is just increasing constantly. It's almost like a fire hydrant, trying to become a fire hydrant. And so I commend you and all of my physicians that I interview about having all of the things you have to juggle in your careers with staying up to date, training training those that you're working with. And are you training, by the way, in these, you said it was fellowship training that you're training?
I'm training residents and fellows.
And fellows. Okay. Are they by chance getting exposed to RFA in that?
They are. So I
That's
actually
cool.
even brought with me to the very first NASIT meeting, brought one of our residents because he was very interested in learning. He's going to be going into head and neck, kind of a more broad head and neck, but is very interested in doing thyroid as part of his practice eventually. So trying to get them early exposure and kind of exposure through both with ultrasound, with FNA, with thyroid pathology, obviously thyroid surgery, and then now with radiofrequency ablation. So.
Oh wow, that is awesome. I look forward to the day when this is just like a standard thing that's taught in medical school, because a lot of patients don't understand that up until now, this has been the sort of thing that you as a physician have had to take that on yourself to go out and seek that training, attend these courses that are, offered from time to time. And you had some training with Dr. Goldenberg, right?
Yeah, I did my fellowship training with Dr. Goldenberg. And so
Okay.
when it was available to do training for radio frequency ablation, and obviously with COVID, it was all like a little bit scattered.
Right.
So he was actually trained before me, which was fantastic and perfect because then once I had training, he actually came and proctored my first several cases, which was, as somebody who's a lifelong mentor, just a fantastic thing to kind of continue that mentoring relationship. Being a fellowship director for somebody who's now many, many years out of their practice or out of their fellowship and into practice, it was great.
Let's talk about how you're doing these RFAs in your practice because you're in a hospital setting, correct?
Yeah, so we have an outpatient clinic, an outpatient
Okay.
surgical center, and then we have an inpatient sort of main hospital base. My practice currently for where I do the radio frequency ablation is actually in our clinic, which is not technically part of the hospital. It's separate. It's in sort of a brand new outpatient hospital building. And we have a procedure room. It's actually where I do many procedures, other than just radio frequency ablation, but it's a great setup. It has plenty of space, all of the, kind of accoutrement that you would want in a procedure room. So it's
Mhm.
great.
Just real quickly, talk us through the procedure step by step because I know there's a lot of people who are just coming to learn what RFA is. There's our community, Save Your Thyroid, has over 10,000, almost 11,000 patients now. And so many of them come straight into the community and say, what is RFA? Briefly tell us what the acronym means and then kind of walk us through the procedure.
Sure. So radio frequency ablation is what RFA stands for. That's a very obviously general term. You could do radio frequency ablation of a lot of different things. And so we're talking specifically about radio frequency ablation of thyroid nodules. In my personal practice, I am still very much kind of narrow in my focus. I am not ablating atypical nodules or nodules that have any sort of like suspicious cytopathology on their biopsy. So just benign nodules and kind of sticking with that until our sort of national and international data really suggests a very clear evidence that it is safe to do it with those indeterminate nodules. I would say like I'm a little bit more conservative on that approach, and I'm happy to have more conversations about that as the data rolls out. But the patients we usually will have come in maybe a couple of weeks ahead of time in terms of like just getting a consultation, sometimes reviewing their imaging if it was done outside, having an ultrasound in the clinic with me, potentially if that's necessary. So just kind of seeing, it depends on the patient where they're coming from and prior imaging and biopsy reports have been. Do like to have the reports at least reviewed, if not maybe the slides reviewed, just to be absolutely sure if they were done outside that
Yeah.
our pathologists agree that this is a benign nodule and are happy to proceed.
I want to interrupt you for just a moment because I
Yeah,
think that's really important to touch on. And I want to comment that pathology, when you're looking at the state of the nodule, you're trying to determine if it's benign, malignant, whatever, that's very subjective, right? The pathologist is using their eyes to determine what they think this nodule is. And so like that you said that you want to review all of this beforehand to make sure that everybody's on the same page, because sometimes we do hear from patients that, one doctor said it was this, but then another doctor said it was that. And sometimes it goes in their favor where, initially somebody may have thought that it was a bad outcome. And then, no, actually, someone with a little more experience came to a different conclusion that was more positive. So,
that's really, really true, Jen. And so much, so much of what we do in medicine is subjective, right? The radiologist reading the ultrasound, that's also subjective.
Mhm.
And so I think as a person who I would say I'm just a very, kind of safe, cautious type of person. And I really like to be 100% sure about all of the different things that I'm seeing when I'm treating a patient. So I like to perform my own ultrasound. I like to, at the very least, review an outside ultrasound and feel comfortable with the images that I'm getting, agree with the radiologist report, see if our pathology team can review the outside slides. I think that aspect too, coming from a large institution that does a ton of these and has phenomenally well-trained pathologists that are just top-notch, top in the nation, I trust their opinion, and they do a great job of, having very few false negative positive results and that kind of thing. So I really do trust that kind of second look or second opinion sometimes for those outside slides or ultrasounds, things like that. For the day of the procedure, a lot of our patients will have been given the option to take an anxiolytic. I would say that was actually something that a couple of my colleagues recommended and has been, I think many patients have found that to be very helpful. Does mean that they need to have a ride there and home. And I think honestly, that's probably pretty appropriate for having a procedure like this. We sometimes don't think about that, like, going to the dentist, having Novocaine, having a cavity filled and then driving yourself home. I think a lot of us have probably done that, and maybe it's okay, maybe it's not, but I generally will recommend, just to be on the safe side, having somebody that's bringing you. You can always have a little inflammation in the neck and some tenderness there. And so if you're driving yourself home and you feel like you're not turning your neck well, I just would hate for that to ever be an issue. So I do think it's just a safer thing. And then again, it allows patients, if they prefer to have an anxiolytic. We kind of go over the steps of the day and sort of make sure that usually I've had a conversation with them well ahead of time about what the day will be like. That allows them to kind of be reassured. It's always very anxiety provoking to be in a situation like that. We oftentimes forget that patients, when they come in to have a procedure, are in a place of vulnerability, that's not where they like being. Nobody likes being there. So I hope that it's both empowering that they're getting to do something that they feel like is the best thing for themselves, and also understanding that this is a place of vulnerability for them to be here, procedure, having something done to their body.
That's what's so great about a lot of patients tell me about these interviews, is it kind of takes down their anxiety just a bit, because they've gotten to see the physician, what they're like, hear about them and learn about them and see them interacting with me. That takes a little bit of the anxiety off, because I'll just tell my own personal story real quick. When I went to see my doctor who did my ablation, the first time I met him, the first time I saw him was the day that we thought we were doing the procedure. And I had just driven 9 hours, and I was, was very anxious because back then we didn't have a lot of the resources that we've created in the past 5 years. So I didn't know a lot about the procedure going into it. I hadn't watched interviews or anything. They didn't exist. So, there's a lot of anxiety there. That's the goal with these interviews, is try to help take that down. Then with the anxiolytic, that helps too. I had some, I believe, Ativan given to me before my procedure, and it did just help to calm things down, help me to not worry, because yes, you're dealing with the patient's neck. There's already anxiety just because of the fact that you're in an area that's really sensitive. There's lots of critical structures there. And so, the anxiety can be high, but having your bedside manner, being with the patient and helping them to calm their fears, that just helps so much. I'm sorry I interrupted you again.
No, that's great. I agree with you 100%. It's so much of it is about, kind of making what can and should be a good thing, a good day, a pleasant experience. It really should be. And especially, when, as surgeons, we are used to our patients oftentimes being asleep, and that's a very different scenario. It's a very different environment than having a patient who is awake. And so just kind of doing whatever you can to make the environment calm, make the patient feel that they're in control, and kind of have that ability to sort of have open communication about, hey, how are you feeling? Is this okay? Are you comfortable? Things like that. It's so important for the day. So patient gets dressed in, we usually ask them to wear very comfortable clothing, nothing with metal touching their skin, that kind of thing. And then they usually will dress in a gown for the procedure. If they have a bra, I'll have them take their bra straps down, just so that we're not, going to have anything there. They get positioned where their neck is is extended, but hopefully not in a way that it's too uncomfortable for them. Obviously, we have to kind of balance comfort for the patient and access for
Right.
us. I kind of, again, liken it to like going to the dentist. Sometimes it's like, oh, my jaw hurts because I've had my mouth open, but gosh, you got to get to that tooth, whatever it is. So it's a similar type of thing. And certainly there's always ample opportunity to kind of reposition or kind of move yourself around if you just need a break for a second. The procedure usually starts with kind of an ultrasound, just kind of taking a lay of the land and marking out areas where you want to sort of mark the top and the bottom and sort of the area where you might use your tiny needle to go into the skin. And that just allows you to kind of get a roadmap for the nodule that you're going to be ablating. And then usually prepping the skin, which means just sterilizing everything and creating a sterile field so that you're doing everything as clean and as sterilely as possible. And then anesthetizing. And that's kind of where, it can really make or break how that patient experiences the radiofrequency ablation. So trying to get as good a block or anesthetization as possible so that the patient is feeling as little of it as possible. And so using those agents and kind of letting them, seep in and sort of really take effect so that the patient's comfortable.
Right.
And then the actual setup of all of the equipment, I kind of feel like that's probably the most anxiety provoking portion of the case because everybody's kind of bustling around and setting up, the different pieces of the equipment and everything in the room. So try and keep it calm. Try and play some music or something like that. And then oftentimes for the ablation itself, it's not particularly long. A lot of it is sort of finding where your margins are, where your danger triangle is, kind of making sure that you're sort of getting all of the nodule ablated. And sometimes it means going back, doing a couple sweeps and kind of saying, oh, I need to get a little bit more in that particular spot. The ablation oftentimes takes less than an hour. And that includes, kind of pretty much the whole setup to being completely done. I usually will have the patient stay with us in the clinic for about half an hour afterwards. We do vital signs during the procedure and then also after the procedure and just make sure they're not nauseous and they're not, having any difficulty with various things. Sometimes I will kind of plan to look at vocal cords afterwards just in case it happened to be in a particularly tight corner close to the nerve. I do have patients talk to me during the surgery, and that's one of the benefits of having an awake patient, even though it might be nerve-wracking for somebody to think, oh my gosh, I'm going to be awake for this. That sounds crazy. The major benefit of it is being able to talk with your surgeon. And so if you're feeling something, that usually is an indication that you're a little bit too close to a structure or your anesthesia isn't quite where it needs to be. So it's sort of a good indicator that, hey, we need to adjust something or move something. So it ends up keeping the nerve to the voice box a little bit more safe, I think. And I think a lot of us feel very comfortable about that. And put a nice pack on it, put a tiny Band-Aid right in the one spot where the needle goes in. And once the patient feels well enough, they go home. And we do a post-op call or a post-procedure call and check in with the patient. And then we usually will see them back at 3 months, 6 months, 9 months, and a year.
And how many cases have you done so far? And what's the interest been in your area?
So I wish that I have done more. I've only done about 5. I've got 3 more coming up in the next month. It kind of seems like it comes in waves. So it's sort of, I had a very, very boring summer, almost none over the summer. And then I've got several that are scheduled just for next month. I would say in this area and with the insurance companies that are here, which is a whole nother, can of worms, a whole nother podcast probably. The payer issues between the hospital and the insurance companies make it such that for the most part, our patients are paying out of pocket for the procedure.
Right.
So I would say interest and my interest in doing this procedure is like astronomical. There are so many patients who would benefit from it. Part of the problem, though, is that many of those exact same patients who would benefit are the exact patients who cannot afford it.
Right.
And so that's really where I'm very hopeful that in the next year or so that sort of begins to change. And specifically in Philadelphia, I feel like even just outside of Philadelphia and some of the areas around, we are seeing insurance companies pay for the procedure and have it fully covered and no issues. So I hope that that's coming for Philadelphia as well.
I agree. Insurance coverage and financial barriers are a huge barrier.
Massive.
So many people. I mean, we have patients who come to the community who say, I really want to have this done, but I just can't afford it. So I'm going to have the surgery. And that breaks my heart because
Me too.
they would prefer to save their thyroid if they could just afford it. So I'm really hopeful that maybe things are going to improve with that, with insurance coverage coming in the next year, hopefully. We'll see. We're going to have to say some prayers and hope
Yeah,
for the
fingers
best.
crossed. Yeah. I do think that, in terms of, my understanding of how, healthcare costs go, which I think sadly physicians are oftentimes kind of kept out of those discussions, we would forego the cost of having an anesthesiologist, having the operating room, having potentially an overnight stay for some of these patients with very large nodules where you may want to observe them overnight. There's so many costs that get eliminated in order to provide this procedure. And for the patient, so many costs in terms of not having nearly as many days missed from work, all of the various things that kind of come down the line with hypothyroidism, just
Right.
so much stuff in terms of like cost benefit analysis that it seems
Absolutely.
like a no-brainer to me. But yeah, I'm not the person making the rules though, sadly.
It's so important. Let's highlight that for just a moment, Dr. Cottrill, because I think it's so important that patients understand when you're having to make this decision, when you are indeed a candidate for a non-surgical procedure, but you end up choosing surgery. And that's not to shame anyone for doing that. That's your decision as a patient. You have autonomy. And it is your right to choose what you feel is the best course of action for you. But if you're interested and you are a candidate for RFA or any thermal ablation technique, we need to think about the cost, as you said, the cost benefit analysis. So when you have surgery, there's always, even with an insurance covered procedure, there's always going to be out of pocket costs, sometimes costs that you're not anticipating. And I'm just talking about the financial aspect right now.
Yeah.
So for example, I remember when I had my two children, the hospital bills came. They weren't all like, oh, pay this much and you're done. You get a bill and then you get another bill for something else. And then you get a bill from the anesthesiologist and you get the bill for hospital stuff. And, there's all these bills and they never are as much as you think they're going to be. There's always going to be more than you expect. And
It's so true.
so the difference, financially speaking, I think, when it comes to surgery and RFA in this situation is that the patient is, if they're paying cash, they're paying out of pocket, it's all up front, right? It's all on the front end. And
Yeah.
you're looking at this price and you're getting a bit of sticker shock. Versus if you have surgery, you could potentially pay just as much out of
If
pocket.
more.
It's
Yeah.
just spread out over time and it's not anticipated because it's coming after the fact. So that's the financial side of it.
Yeah.
Then, as you were saying, you have to consider the health costs, the costs of losing your thyroid, the cost of being hypothyroid. What does that do for your health? There's so many things that are impacted by the thyroid that there are potential costs there for your quality of life. And not to mention, and this is not to demonize thyroid surgery, but thyroid surgery comes with a scar. It comes with a lifelong need for thyroid medication. So, I don't know if you have any additional thoughts you want to add there, but those are the things that I always think patients need to keep in mind when they're comparing surgery to a thermal ablation procedure.
Yeah, I think, there's so many things that go into both, a personal decision to make, especially now that there are more options, right? So it just
Right,
makes the conversation, honestly, sometimes a little bit harder, a little bit longer, a little bit more
right.
complex. I do have many patients who have this feeling of like, I just want it out of my body when there's a nodule there, even if there are benign biopsies times two, even there's something about it that like they just don't want it in their body.
Mhm.
Totally understand, totally good with that. We've got a way to do that.
Mhm.
It's really, I never approach a patient with I want to talk you into or out of
Yeah,
anything.
definitely.
It's more I want to give you whatever information will help you make the right decision for you. And sometimes that means, sending them to different websites and sending them to talk to other patients, sending them to forums, things like that, so that they get more of a sense of sort of what they're in for in terms of long-term outcomes and prognosis.
Mhm.
I keep a file on my phone so that I can show patients like this is what a scar looks like. And if that's an absolute no for them, that's helpful for them to see that picture ahead
Mhm.
of time. I think if you Google it, it might look a lot more scary than like what my pictures look like, but it's
Yeah.
still there. It's still there. Even like the most beautifully well-heeled ones, it's still
Mhm.
there. And so everybody has to make that very personal choice for themselves. There is also a cost of the follow-up and things like that. And so you may have patients that are kind of weighing those issues as well. I will say I don't know how it is in other practices, but for our particular group, because we have a large department that includes a very vibrant and very productive facial plastics department
Mhm.
or division. And so we already through our department have like payment plans basically set up for lots of other procedures that people come in and pay cash for, blepharoplasties, facelifts, things like that, Botox, you name it. So the method was already in place for us to have payment plans for folks, which is extraordinarily helpful, right? If you are looking at that sticker and getting that sticker shock, well, okay, I can pay this in, 2 years time and make payments that are going to be much more reasonable for me. But again, so
Fantastic.
much of that is very, very personal. And it's kind of everybody to make that decision for themselves for sure.
Definitely. I'm glad that you mentioned that about the payment options, because that's something I've mentioned to so many physicians that I've talked with over the last few years, is that, you need to have something in place like that to help with this, because it is a lot of money to consider all at once coming out of your pocket. And that's going to break down that barrier for a lot of patients. So I'm
Right?
really
Yeah.
glad you have that in place. That's fantastic. I'd like to take a moment to thank the sponsor of today's episode, RGS Healthcare. RGS Healthcare has been a leading medical imaging equipment distributor for more than a decade. RGS is known not only for recommending personalized medical equipment solutions, but also for offering continuous support to ensure success. One thing RGS is particularly known for is unparalleled physician training and on-site staff support. They are the only medical equipment supplier known for accompanying their doctors to exclusive, specialized thyroid RFA physician training on live patients proctored by leading world experts. If you'd like to learn more about RGS Healthcare, please visit their website, rgshealthcare.com. A heartfelt thank you goes out to RGS Healthcare for supporting this channel. Now, back to the podcast. So it sounds like a lot of your time really is dedicated to thyroid care, just in general with your practice. Is that the case?
Yeah, so my practice, I would say, is like 99% thyroid.
Oh my goodness.
I still see a good number of patients that come in with just a generalized like neck mass or lymph nodes that are enlarged, things like that,
Mhm.
work them up and, kind of have those patients that are sort of, again, part of my practice. Oftentimes, if they end up, I end up diagnosing them with tonsil cancer, tongue-based cancer, lymphoma, things like that. They're getting managed by other colleagues of mine, but those are patients I'll still see as a new consult. I don't have kind of a very narrow, you only are going to come in if you have thyroid or parathyroid disease.
Mhm.
And I do actually do quite a bit of parathyroid surgery as well, but that's my practice, I would say, is about 99% or so endocrine.
All right. Very
Yeah.
cool. And I would just love to hear your practice philosophy. I think I kind of have a sense of it already. I would love to hear just straight from you. What is your practice philosophy?
So I saw this on your questions and I struggled to like put it into a nice catchphrase.
I understand.
But
That's
I would
kind of
say
a big
that in
question.
general, what is your philosophy on life? It's something that I would say my hope is always to bring the patients as much information as they need to make the right decisions for themselves, and to bring them evidence-based information specifically. Would say also just my philosophy for practicing care or being a professional is simply respect of individuals. That probably is like the absolute basic
Yeah.
underlying foundational principle. So respect for their autonomy, respect for their decisions, respect for any of their cultural beliefs, any of that. Like it's that's kind of my approach.
Oh, wonderful. I love that. I love that so much. I think you and I are on the same page here about educating the patients. That is our goal at Save Your Thyroid, is to make sure, same thing you were saying a second ago about, we're not trying to persuade anyone towards a procedure or away from a surgery. Our goal is to educate them, provide them with information and resources, and help them to make sure that they know all the things they need to know so that they can come to that decision on their own. Because truthfully, some patients come to our community and they are so dead set against surgery, and they're insistent that they have a procedure. And that's not a good outcome necessarily. What if you're not really truly a good candidate for this procedure? So we're not trying to demonize surgery, but we're also not trying to persuade anyone to do any particular thing. We just want them to know that when they lay their head on the pillow at night, that they've done their due diligence, and they've made their decision based on facts and data and not fear. And
Yeah,
so I love all of
absolutely.
those points you made. Because you're a surgeon, and this is a question I love to ask surgeons, because surgeons do surgery, right? And so many patients even have this kind of misguided understanding that surgeons just love to do surgery and that's all they want to do, and they're not interested and open-minded in non-surgical options. So how is this type of procedure, radiofrequency ablation, changing your surgical practice?
I'm glad that you brought that up. And I actually wanted to kind of maybe even bring in another aspect, which is active surveillance, right?
Mm-hmm.
So many of the nodules that we're talking about, whether they're microcarcinomas or benign nodules, we can simply do active surveillance for. And I think
Mm-hmm.
education around surveillance is also very important for people,
Right.
especially when they've just found out I have a nodule. It freaks a lot of people out, like, oh, I've got a growth, and here it is, and oh my
Mm-hmm.
gosh, I didn't know that this is here. It's just simply educating people about what are thyroid nodules, and what are they going to do over time, and how will they affect me, and what will my long term, will I feel it, will it grow, all of those questions. There's so many things just around that kind of education
Mm-hmm.
that are incredibly important. And as an option, I will say, as a surgeon, I love to operate. It is one of my life's joys to operate. It is something that I feel like I am both good at and also can do good for people with. It's like a skill that I get to give to other people as a gift,
Mm-hmm.
but only ever want to operate on people that I will help.
Right.
And that's really, that's really where it kind of comes down to the mindset, the understanding, and a personal choice that just has to be, as you said, when you lay your head on the pillow at night, that you've made the best decision for you based on all of the evidence. And so I do, talk with my patients about all of those different options, surveillance being one of them. And, as you were mentioning, kind of always keep that hopeful, always cool stuff on the horizon. Like maybe radiofrequency ablation isn't for you, but maybe the next cool thing will be. And
Yeah.
so I'm thinking about what neat things might be coming down the pike at some point in time,
Mm-hmm.
that might allow us to be a little bit more safe, a little bit less heat, a little bit, all of those things. I think I'm a big believer that we've got more cool things coming, and there will be other opportunities. So if the decision is I'm going to watch this and see what comes about, okay, I'm cool with that.
I believe that having a surgeon with multiple tools in the toolkit, like you were saying, active surveillance, radiofrequency ablation, surgery, all of these things, that's so important, because
Yeah.
you're not biased. I mean, we all have our own biases, right? But when you have multiple tools in your toolkit, you're not going to only use one of them all the time. You're going to be looking at all of them and saying, I believe that this one is the best for you. And you're going to be able to present evidence toward that end. So I think that's so awesome to have that perspective.
Absolutely.
Did you have any other things you wanted to talk about? Any papers or research that you participated in that you'd like to cover?
I would say, yeah, that was such a great question. And I don't have any that is very specific to radiofrequency
Okay.
ablation. The studies that I am currently doing kind of go back to my interest in patient education,
Oh,
actually.
wonderful. Okay.
And so I currently have a clinical trial looking at the way in which we discuss thyroid surgery with our patients, and just
Mhm.
how they understand risks, benefits, that kind of thing. And then also that same study looking at patient regret, how we make those decisions and whether or not we regret the decisions that we made. So it does have a little bit of play into this discussion.
Yeah, I would love to
Um,
hear about both of those if you want to talk about that for a moment.
Sure. The genesis of it was actually during COVID. A group of medical students came to me and said, we're really bored. We have nothing to do. Do you have any
Oh.
projects we could work with you on?
Mhm.
And at the time, I had been in practice for a couple of years and had been really wanting to find better ways to consistently talk to my patients and educate my patients about what this thing was that I was going to do to them, right? Like I don't ever want anybody to just say, whatever you say, doc, sign me up for it. I'm good. It just makes me not, again, from like my philosophy and ethics background, it just makes me not feel so great. I want them to understand and really truly have informed consent to a procedure.
Definitely.
So a lot of this came out of this nice little time period where I had these phenomenally talented medical students who asked me about a project. And I said, hey, let's make a video that takes a patient through what all of the risks and benefits of surgery are and uses pictures and animations to help with that education. As you know, a lot of what you get from your surgeon when you go in to talk with them about anything, whether it's a procedure like radiofrequency ablation, is verbal. Is entirely verbal. And we're not all verbal learners. It also may be at the same visit that you just got told that you have thyroid cancer. And like once the C word comes out, like all the brain cells are like, I'm not listening to anything else, right? So having a conversation with a patient about very serious things like, I need to tell you about the risks of this procedure, how you're going to feel afterwards, how you're going to take care of yourself afterwards. It's just overwhelming for most patients in that time period. So we made this video. It is actually available on YouTube for anybody who wants to go see it.
I'll put
and we
in the
actually
description of the video so people can look at it.
Awesome. We actually translated it into Spanish and Mandarin as well. I would love to have it translated into other languages, just because so many times that's also a big barrier to understanding when we have even a translator in the room doing verbal, word for word, it sometimes is still not quite the same as somebody explaining it in their own language in one full sentence, I'll say, instead of bits and clips and that kind of thing. So this video we used in my practice to kind of augment the consent sort of process that I was doing, and also made a QR code for them, put it in their pre-op folder and said, go home and watch this with your family so that everybody's kind of on the same page about what you're going to be having done. So that's kind of the way I used it initially. Because actually a friend of mine was like, why don't you study this, Beth? You're really interested in patient education. Why don't you actually publish a study about how it's affecting your patients and how it's helping or if it's helping? And so I said, oh, that's real smart. I should probably do that. So we are doing that. So it's a clinical trial. And we decided as we were putting it together to actually include some other things about what do I know ahead of time? What's my education level? How much did I go research this before going to visit somebody and talk about it? Those kinds of things all may prepare somebody a little bit more for listening or receiving that information versus if this is the first time you've even thought about, oh my gosh, you're going to cut me open and remove this thing. And all of that is can be very jarring if it's the first time. And so we put together some various surveys, validated surveys that are about the decision-making process. And then at the time of their appointment with me, we kind of ask them if they want to participate. If they do, we randomize them into either receiving verbal, the regular consent, just me talking, or whether they see the video first. And so then they kind of get a little bit of, is the video going to be better at educating them than my verbal? And it is actually just me talking in the video. So it's still me, but with pictures, videos, animations.
The ability to go back and listen again. And, because so much of what you are being told, you might even forget. So there's other benefits there too. Wow. Okay.
Yeah.
Wow, that is
so that's the study. We're kind of in the midst of it and hopeful to publish it within the next probably year or so.
Oh, wow. I would love if you can remember at that point to let me know. I would love to look at that. And what about the patient regret after surgery one also?
So it's more decisional regret, not like, not like, oh gosh, I wish that my thyroid was still functional or, something like that, because obviously there's a lot that plays into it. Some patients, I think it's 46% or so, will go on to require thyroid hormone medication, even with normal hormone levels in the before surgeries, if they're having a hemi. I'm just talking about half. And that's obviously like a whole nother aspect of it. But this is sort of like, did I get all of my answers, my questions answered? Did I actually ask all the things I needed to ask to feel comfortable? Basically, did I rest my head on the pillow knowing that I made the right decision? It's that question.
Oh, wow.
And so those surveys go to patients right at the beginning and then also after surgery, about a month or so after surgery. So
And is that still in process too?
Yes.
Okay.
Yeah. It's
Okay.
all part of the same big study.
Okay. I see. Wow. That's very interesting to me. I think you and I have a lot of similar interests here. So yeah, I would love to look at that when it comes out. Thank you for sharing that. Very cool. Thanks so much for watching this episode. I hope you're enjoying it. You know, this podcast requires a lot of my time, effort, and resources, but it is a labor of love. If you'd like to directly support my work here, you can do so in 2 different ways. You can purchase products from one of my affiliate brands, or if you would prefer to make a donation directly to the podcast, you can do that as well. Links to do either are located in the description below. Every dollar contributed goes right back into this podcast. Additionally, if you'd like to support the Save Your Thyroid patient advocacy community, which is working toward becoming a nonprofit organization, you can donate via our fiscal sponsor, THYCA, Thyroid Cancer Survivors Association. Simply visit thyca.org, click donate, and designate your gift for SYT. To learn more about us and the work we do, please visit saveyourthyroid.org. If you have any questions about any of this, don't hesitate to email me at saveyourthyroid@gmail.com. Any way you choose to support the podcast or the SYT community is sincerely appreciated. Your generous contribution keeps this work going and helps us to help more patients like me and you. Thank you so much for watching, and now back to the podcast. Is there anything else you would just like to share to kind of anything else you want to let the community know about yourself or your practice or radiofrequency ablation?
I guess I would just say happy to have anybody come from anywhere to Philadelphia. Happy to see them and to provide whatever care and help and assistance with making decisions about your thyroid that I can possibly, be a part of. I would say it oftentimes takes a village. And so having a full team, primary care that's behind you, an endocrinologist and a surgeon or proceduralist, whoever is kind of that person for you. It's really important to have lots of people kind of involved. And I love that aspect of my practice, having an endocrinology team that is very robust and very informative, very interactive with our patients.
Mm-hmm.
Pathology, radiology, all of those folks just always on the phone with me. Hey, Beth, I wanted to tell you about this or that. So just having a good team that's behind you, very important.
So important. I'm gonna throw one more thing at you, Dr. Cottrill. Please tell me your elevator pitch for saving the thyroid. I would love to know, if you're on just a brief, I have just 30 seconds to tell someone why they should save their thyroid. What would you say?
Oh gosh, I would say because it's possible. That's really the coolest thing about it is, this didn't actually, this wasn't even on our radar. I don't want to say it didn't exist because as a technology, it has for a long time, but this was not on our radar even just 10 years ago.
Mm-hmm.
And now it's an option and it's a great option for many people. So, finding the thing that is sort of like the least invasive is so awesome for a large number of patients.
Thanks so much for listening. Please share this content and help others. If you need resources, testimonials, and support, please join our patient community, Save Your Thyroid. You can also find me on social media and Substack under the media handle It's Me Again. Never forget to educate yourself and be your own advocate and save your thyroid.